Good morning, everyone. I would like to warmly welcome you all on behalf of the President and the Council of the Ceylon College of Physicians to our first specialty update for the year. And we are very grateful for the Sri Lanka College of Cardiology to partnering with us to conduct a very successful, informative lecture series of lectures today. I am very grateful for the President of the Sri Lanka College of Cardiology, Dr. Mayurudan, and his council for being with us today. So I would like to invite Dr. Mayurudan to introduce our first speaker.
Thank you, Dr. Modidasa. Our first presentation will be on updates on ST elevation myocardial infarction. It will be done by a well-known cardiologist of this country, Dr. Vajra Senaratna. Over to you, Dr. Vajra Senaratna.
Thank you, Tuminder, and the President of and the Council of CCP for inviting us at the College of Cardiology to take part in this important symposium. My topic, of course, update of the stimulation myocardial infarction is a very applicable topic for the day, and I have no interest, financial interest or conflict. The important thing is we know that it is the #1 killer worldwide. And out of 3/4 of cardiovascular deaths occur in low and middle income countries like Sri Lanka. And we see now, day by day, incidence of coronary disease rapidly increasing among young population. We see a lot of young people coming with acute myocardial infarction without obvious risk factors. I'm sure you have seen this many times, but I would like to start because this is the basic pathophysiology of acute coronary syndromes. The plaque develop over the years, start developing maybe or start with 10-15 years. This due to our negligence or not appropriate action taken, they develop lipid plaques in the subendothelial area, and the day it causes plaque erosion or plaque rupture, the blood exposed to the underneath tissue causing platelet aggregation. It causes platelet thrombi causing white thrombi, and then gradually progress to the red, the fibrinogen join and cause a large thrombus, red thrombus. And it presents with like unstable angina or non-Stemi when the plaque, the material, the platelet thrombi get embolized, cause microinfarcts causing troponin I causing non-ST elevation, or the vessel totally occluded causing ST elevation MI. So these three categories, ST elevation MI, non-ST elevation are very common, but both conditions, the morbidity and mortality are almost the same. The clinical diagnosis of paramount importance in making a proper management. Because most of the we see without taking proper history, patients are being treated for acute coronary syndrome. Sometimes you miss ST elevation MI by not taking proper history. The typical presentation is the angina. Typical angina is tightening, compressing, burning, or heavy thing. In the center of chest, it extends from epigastrium to the lower jaw, like epigastrium, retrocularia, throat, lower jaw, and teeth, and could radiate to both arms and go back to the back of chest and associated with autonomic symptoms. So this is very typical. So when you get these symptoms, you must suspect acute coronary event. Diagnosis, I think you should know. The important thing I would highlight, inferior myocardial infarction, always we should take V3, V4, because that is the one causing high morbidity, high mortality. If you miss a right RV infarct, the inferior, the two problems are complete heart block, it can be reversed easily, but when you get a right RV infarct, that can cause a lot of disaster like hypotension episode, cardiac shock. So that has to be diagnosed early and take prompt action. And this is the ECG of true posterior MI. You can see the ST reciprocal ST depressions in V1 to V3. These patients almost always should do posteriorly, V7, V8, and V9, that will show ST elevation. So it's very important that you should do V7, V8 to make a proper diagnosis. And this is left bundle branch, all of you know, but the patient presenting with typical symptoms of left bundle branch block, probably he may have been all ECG normal, but sometimes you may not have the all ECGs, you always suspect acute coronary event. And this is right bundle branch block with ST elevation. And if you have ST elevation, typical symptoms, because this one of course shows ST elevation, then you can make ST elevation diagnosis in mind. But that indicates that extensive damage to cause right bundle branch, the damage has to be extensive. So it indicates extensive myocardial infarction. And this is a chest pain with pacemaker. Anybody having with pacemaker, it's a little confusing, but you can see ST depression, ST elevation. But history is the most important thing. And this is a very common percentage. I think almost all of you, I think, know this. Diffuse ST elevation with ST elevation, diffuse ST depression with ST elevation AVR, that signifies critical left main disease or critical three vessel disease or left ventricular. So these patients should go to cath lab as early as possible. If you delay, there could be high morbidity, high mortality. And there are occasionally the atypical presentation, then you get hyperactive T inversions. When you highly suspect and you do repeat ECG to confirm it, or sometimes occluded circumflex acute occlusion of vein grafts, left main disease may present without ST elevation. So as I would reiterate the importance of making a proper diagnosis. So ECG alone won't help you. But this scenario, if you have an echocardiogram, then you can look at the wall motion abnormality. That will confirm that even the STs are not there. You do echocardiogram, the history suggests you do echo, you can see the wall abnormalities, anterior wall apex, and receptor, you know, that's extensive anterior MI. Usually we are guided by these two colleges, SEC and ESE. We follow, of course, we don't have our own guidelines, so we follow these things. Mostly the ESE. And the management of the goal is, you know, time is muscle. More you delay, more damage. So we have to achieve prompt, complete, and sustained reposition, that is Stemi 3 flow of the infarct retard. So there's you have to act as early as possible. As you can see from this slide, very clearly this, as you delay, the mortality reduction becomes less and less, and as you go after 3 hours, 4 hours, it becomes less. So that is why you have to act very early. And how can you improve? There are, this diagram present of the delays which can occur and how can we control this. There's a patient delay, you know, in spite of repeated lectures, TV programs by doctors and other people, still patients don't come on time. That is very sad, including doctors. Doctors are people who come in last. And the ECG system delay, when you come to the hospital, you have to take an ECG within 10 minutes and make a diagnosis. But I don't know how much delay happening in the hospitals. We know when you come to ECG, take ECG. ECG technician go into ward rounds and something, but this is very, very critical, bad situation. And also once you make a diagnosis, you have to act promptly. As I said, muscle is time is muscle, therefore act quickly. You have decided either you have to, the medical management won't help, either start thrombolysis or PCI. These are two options for us. And this is the management protocol. If a patient comes first to a PCI center like National Hospital Colombo, you make a diagnosis within 10 minutes by doing ECG, you can see ST elevations. Then you immediately transfer the patient to the PCI lab, not to the CCU, not to any other place, directly coordinate with this, minimize delays, and send to the patient for reposition. That is, we don't talk about need to balloon time anymore. We talk about door to wire crossing time. Sorry. And the patient comes to non-PCI centers, instance goes to Ragam Samya. What to do? Again, you make a diagnosis within 10 minutes, and depending on the time delay, you have to decide. If you think you can get the patient through to the cath lab and get the vessel open within 120 minutes, you transfer the patient to for PCI. If there's a delay, you have to do immediate thrombolysis within 10 minutes. Within 10 minutes. I would like to highlight this guideline with cases. This is a patient, a 55 years old patient, presented to Basel Panadura with chest pain for 2 hours duration. ECG shows anterior stimulation. MI, no contraindication or thrombolysis, expected delay with the highway maybe 45 minutes assume. What is initial management? Most simple, as they come in, you go aspirin and what you dual antiplatelets. You give aspirin, of course we don't have IV aspirin. And then mostly the acute myocardial, acute coronary ischemia, what you should give is either prasugrel or ticagrelor. I don't know how many hospitals you have this. It's not in the government hospital, as far as I know. But if you have it, that is the best to give, because these are standard type class 1A indications for acute coronary syndrome. If neither is available, you give clopidogrel 3 to 600 milligram loading dose. And cangrel, of course, not available. That is a very good drug, gives quick action, onset and offset action. Then action wanes off within few minutes. And then, you give all the patient, when the patient comes, chest pain, you see everybody with a face mask. Is that right? Absolutely no. If the saturation is less than 90, they need oxygen. If the saturation is more than 90, they don't need oxygen. Actually, it's 3B that is harmful. It's not actually not only good, it is harmful. Therefore, you should never give oxygen to a patient with saturation more than 90. And also, commonly they are having chest pain, so we have to give pain relief like major analgesia, like opioids. The disadvantage, if you give opioids like morphine, it slow uptake, delayed onset of action, and diminished effect of antiplatelet. So that may be adversely affect the action of this the antiplatelet effect. And also, if your patient is only anxious, you can manage with tranquilizer like benzodiazepine, like diazepam, to keep the patient calm. So once you give the basic treatment, antiplatelets, oxygen and all that, reassurance, pain kill, then you have to decide what is the basic management. If the patient comes to like Colombo, if primary PCI, immediately you consider send to the cath lab for primary PCI. I know it is not possible, practicable, but that is what you should target for. The patient of non-PCI center, if the delay is going to be more than 120 minutes, patient should be given thrombolysis immediately within 10 minutes. But if the patient delay is less than 120, patient should be transferred to primary PCI center for opening up the artery. That's what. So if the patient is here, assume our patient from Paradu, we assume that patient could be sent to cath lab and open that within 120 minutes. You immediately transfer the patient, inform the cath lab in advance, keep the cath lab ready, and do primary. That is the best way of managing these patients. And if you look at the guideline, reposition therapy is indicated in all patients with symptoms of ischemia less than 12 hours duration with persistent ST elevation. So all these patients should be given reposition, either thrombolysis or PCI. The primary PCI strategies are recommended for over thrombolysis within indicated hours. I mean, if the patient comes early, thrombolysis, PCI is the best, not the thrombolysis. But first 3 hours, of course, thrombolysis is also very effective. If timely PCI cannot be performed after ST elevation, MI fibrillary therapy is recommended within 12 hours. So it's going up to 12 hours. As you go on, you get more and more thrombi formation, then thrombolytics won't be effective. So all three are 1A evidence. And, And then, as I said earlier, prasugrel and ticagrelor, or if clopidogrel not available, clopidogrel is the drug of choice given for these patients. And after all that, you give in the cath lab unfluorescent heparin. If you have heparin-induced thrombocytopenia, you have to use biology, which is not available to us at the moment. We had it few months ago, few years ago. Pontoconazole is contraindicated because it can cause catheter thrombosis. And routine post-procedure, post-angioplasty angiogram therapy is not indicated. Then I move to the next case. There's a 65-year-old patient admitted with chest pain for 2 hours, diabetic hypertension, risk factor smoker, ST elevation, myocardial infarction. The expected delay is minimum 3 hours. What are we going to do? Obviously, we have no cath lab in the near vicinity of Ratnapura, so we have to do Colombo. It took more than 3 hours. So we should decide what to do. We see what you do. You can give full dose fibrillary therapy and urgent transfer PCI, whether to transfer immediately for primary PCI, that is out as I said, and start glycoprotein 2B3, and no, that is not okay. So what you should do in these patients, as guideline indicates, if not if PCI not possible, you do immediate thrombolysis. As I said earlier, the time is muscle. So we have to give thrombolysis in this particular patient. What are the available thrombolytics? Fortunately, we have TNK now. Earlier, mostly to a streptokinase. If you give streptokinase, TIMI-3 flow, I don't know whether you know TIMI-3 flow means when you have occlusion, if they're totally occlusive, we call TIMI-0 flow. If a trickle of blood going down the vessel, we call TIMI-1 flow. If it takes about 4 or 5 cycles to fill, we call TIMI-2 flow. The brisk flow we call TIMI-3 flow. So what we expect to target to have TIMI-3 flow, but streptokinase provide only about 32%, but TIMI-2 to 3 about 50%. TIMI-2 also okay, reasonable, but with TNK you get about 60% TIMI-3 flow and 2 to 3 about 80%. So that is quite good response. So fortunately we have TNK at the moment. At the most hospitals they use TNK now. These patients, what should we give antiplatelet? Aspirin, obviously, you have to give. We cannot give ticagrelor or prasugrel because those are potent when they have high risk of bleeding. These patients should be given only clopidogrel. But after 40 hours, when the thrombolytic effect is gone, you can go back to the potent antiplatelet like prasugrel and ticagrelor. And enoxaparin, again, all these patients, if you go TNK, all the patients should be on given enoxaparin, 30 milligrams IV stat followed by 1 milligram per kg, maybe up to the hospital stay, or as soon as you do the PCI, you can stop giving enoxaparin. The elderly patient, you know bolus, enoxaparin only give 0.75 milligram per kg dose till such time the patient needs it. Heparin or pontoparnex also can be given in the patient who are managing with thrombolysis, not with PCI patients. And now this patient you give aspirin 300, clopidogrel 300, atorvastatin, interventional enoxaparin. What is your next step? Now we should decide, we have given thrombolysis, how effective it is. We should know assess whether the medical thrombolysis is successful or not. How do you assess it? If unsuccessful, the ST secondary dissolution less than 50% within 60 to 90 minutes after. So you can't just give thrombolysis, go home and sleep. You have to assess the patient within 6 to 9 whether it has come down, at least 50%. Or presence of, if the patient has hemodynamic and electric instability, you have to transfer the patient, or worsening ischemia or persistent ischemia. All these patients we need that we know it is not successful, we have to do something more than thrombolysis. So these patients you transfer to PCI capable centers for rescue PCI. Once you give thrombolysis, if fails, you send for rescue PCI if the following are present, like failed thrombolysis. Sometimes you can get reocclusion of these arteries, life-threatening arrhythmias or cardiac arrest. This is not uncommon. And also with extensive anterior MI, there could be acute heart failure, hemodynamic instability, or mechanical complications like valve rupture, mitral regurgitation, septal perforations, or free wall perforation. They should be immediately sent to a PCI center or a major center for surgical intervention. Now this patient, now as I told, we have given thrombolysis, immunothrombolysis within 10 minutes. Then what to do? Then if the failed thrombolysis, as I said, it should be sent to rescue PCI, to the center, to a PCI center. Case number 3, I think you understand. If you have any questions, you can ask, I think, after the lecture. There's a 42 years female presented with 2 hours of onset chest pain, anterolateral MI, success thrombolysis TNK ST come down, patient symptom free. Isolaspirin, clopidogrel, statin, beta blocker, and enoxaparin. What is the next step? Now we have given thrombolysis, patient come early, patient far away place, we can't give PCI, so we give thrombolysis. Now what are we going to do? This is our guideline. early angiography within 24 hours is recommended if symptoms are completely relieved and ST segment elevation is completely normalized, spontaneous or after ETN. So even it is calm within 24 hours, patient should need angiography. I know this is not practicable in our setup, but this is our goal. One day we have to achieve this goal. So this is a diagram representation. I will show you how immediate fibrillation. It fails. I told you we'll do a rescue PCI. The balance of patient, you give thrombolysis, successful reperfusion, patient symptom free. Still, you should try and do angiography early within 2 to 24 hours. So successful thrombolysis doesn't live there because we need to give the thrombolysis, it dissolves the clot, but the disturbed plaque will be there. If you don't fix the plaque, it might thrombose again or restenosis again. So all these ideally should be angio and do PCI. I got a fourth case anytime. For 60 years male presented with TH to Raghav Hospital with the chest pain, 16 hours. Now patient has been having chest pain for 16 hours. ECG shows infralateral MI, hemodynamics stable, no indication of thrombolysis. What is the next step in the management? In patients, this ESA latest guideline is in patients with time from symptom more than 12 hours. Primary PCI strategy is indicated in the presence of ongoing symptoms with hemodynamic instability or life-threatening anemia. All these patients should be having angio and angioplasty. Because thrombolysis, I said after 12 hours, there's no point giving thrombolysis because already the large thrombus burden, it cannot be dissolved with thrombolysis, so you have to do primary PCI. The patient coming late, ongoing chest pain, you have to do all these patients. The number 5, this is a 60 years old female patient with chronic AF and on warfarin developing anterolateral MI. You know, this patient, the risk of bleeding is quite high, so inevitably they are not suitable for thrombolysis. So oral anticoagulation is a relative contraindication for fibrinolysis, and they should try to primary PCI strategy regardless of the time delay. And patients should receive additional parenteral anticoagulation regardless of whether they are on anticoagulation. So whether they are on anticoagulation, you have to give heparin during the procedure, otherwise they can get thrombus. And glycoprotein 2B3 are avoided because of high bleeding risk. So this patient loading aspirin as usual, you give 300 dose. And you can't give prasugrel or ticagrelor because high bleeding risk, you give only clopidogrel. The drug of choice, you can give 600 ml loading dose before PCI. And ideally, chronic anticoagulant regime should not be stopped during the admission. You should continue. So these patients after primary PCI, the post-procedure triple therapy for maximum 6 hours, we of course try to minimize it because of the high bleeding risk. Particularly elderly people or renal failure patients, like we try to reduce the dose. And after 6 months, of course, you make dual therapy like antiplatelet and anticoagulation. After 1 year, you continue only anticoagulation therapy. Actually, our management doesn't end there. You go thrombo PCI and send the patient home. No, we have to take care of the patient post-op. This patient has to be in ICU for 24 hours minimum, and stable patient with minimum day, you do echocardiogram. If the patient LV function normal, there no arrhythmia, we know that stable patient can be sent home within after 48 to 72 hours. Nowadays, they recommend even you cannot in guideline, but they recommend even after 24 hours, the patient is stable, no damage to, no arrhythmia, you can send after 1 day, provided that somebody there at home to take care of the patient and live in the close vicinity. And also, you have to make sure that behavioral modification like stop smoking, all the other advice, exercise, all this to be addressed. Most important thing is nutrition. You have to advise about nutrition, that's part of management of myocardial infarction. And of course, you can go diet protocol with the dietitian, and then cardiac rehab. Unfortunately, this is not much practice in the private sector, but for good, thanks to our cardiologists, we practice most of the government hospitals, and it gives reduce all-cause mortality by 11 to 26%, cardiac mortality by 26 to 36%, and unplanned hospital admission by 28 to 6%. You can understand how beneficial by cardiac rehabilitation for this patient. If you look at the guideline, particularly in the cardiac rehabilitation program for patients hospitalized for acute coronary event or revascularization is class 1A indication. So all these patients should undergo cardiac rehabilitation. They take home messages. Early diagnosis and prompt initiation revascularization therapy is the key to success in management of ST elevation in MI. Reperfusion delays could be minimized by educating patient population and improving care in emergency department. And develop infrastructure maximum usage of available cath lab facilities for patients with acute coronary events would significantly reduce the cardiac morbidity and mortality. And educating children from early days to healthy lifestyle would the only long-lasting solution for this ever-increasing but preventable disease. Thank you.
Thank you, sir. We will take the questions after the end of all the presentations. So the virtual audience can type the questions on the Q&A box available on the virtual screen, and also we'll take the live audience questions also at that time. So moving to the second lecture, I would like to invite Dr. Madhu to introduce the speaker.
Thank you, Dr. Munidasa. The next lecture will be by Dr. Tanya Pereira, Consultant Cardiologist, National Hospital of Sri Lanka. She will talk on updates on non-ST elevation myocardial infarction and unstable angina. Over to you, Dr. Tanya.
Thank you, Mayurudhan. I'd like to thank the President of Ceylon College of Physicians for giving us this opportunity, and good morning to everyone here. So these would be updates on non-STEMI and unstable angina. So there will be a little bit of overlap, I think, with the earlier speakers, so I will do those slides a little bit fast. So what is a non-STEMI? These patients classically present with acute chest discomfort, but they have no persistent ST elevation on their ECG. The ECG changes can be of several forms. You may get transient ST elevation. You may get persistent or transient ST segment depression. You can get T wave inversion. You can get a flat T wave. You can get pseudo-normalization of T waves. And of course, you can just get a normal ECG as well. So the key pathology, as stressed by the first speaker, is the cardiac myocyte necrosis. So this occurs in non-STEMI versus no cell damage in unstable angina. So the guidelines are quite extensive, so just to make it a bit interesting, I thought we'll do it in a case-based format. So our first case is a 46-year-old man. It's a very common presentation to the emergency. He presents with retrosternal chest pain, sweating. His ECG has a right bundle branch block. So the standard troponin I is done, and it is normal. So now, the question is this an acute coronary syndrome? And what is the next investigation, or can we discharge him because the troponin is normal? So first is, how do you interpret the right bundle branch block? So if you get a right bundle branch block, the first thing you need to look at is whether there is ST segment depression in lead 1, AVL, V5, and V6. So if you do have that, that is strongly indicative of a non-STEMI. The next is, are we happy with the standard troponin that was done? Well, currently, with the new guidelines, we are not. Because what we really recommend is this high-sensitive troponin I. What makes this so special? Now, a high-sensitive troponin assays are recommended over less sensitive ones because they have a higher diagnostic accuracy and cost is identical. They also have a higher negative predictive value for acute MI. In addition, they reduce the troponin blind interval. I'll just go to the next slide to show you this. Now, if you look at this is the conventional assay of troponin, which comes in micrograms per liter. And this is a high sensitive assay that comes in nanograms per liter. So now if you look at this large area here of patients, we'll consider them positive because troponin is positive. But if you look at the negative, now all these patients here, we say are going to be normal because they have a negative troponin. But that same group of patients who do a high sensitive assay, a large percentage of them would actually become positive. So this area of actually missing this group that we would otherwise have called normal can be eliminated by using this high sensitive troponin. So that's why we say it reduces the blind interval. So it results in a 20% relative increase in detection of myocardial infarction. And even at our ETU in a national hospital, we are always using this high sensitive troponin assay. And actually it is the ranges differ even according to the sexes. So this is the ranges from our ETU, that is for males and females. You can see that the ranges are different. So now we have this patient that we were talking about who came with the right bundle branch block. His troponin was normal. So of course what you're going to do is you're going to do the high sensitive troponin. So now this comes back as 3 times the upper limit of normal. So now what are you going to do? Now this is 3 times upper limit of normal. Are you happy to diagnose an acute coronary syndrome? Or are you going to repeat his troponin? So what is the value of high sensitive as a quantitative marker? Now elevations beyond 5-fold the upper limit have like more than 90% positive predictive value for an acute type 1 MI. So we're talking about 5 times upper limit of normal. Now our patient had a 3 times upper limit. Now elevations up to 3-fold the upper limit reference have only limited, they say 50 to 60% positive predictive value for an acute MI. And they actually may be associated with a broad spectrum of conditions such as aortic dissection, pulmonary embolism. And also it's important to know that some people do have circuiting levels of cardiac troponin in their own bloodstream. So, but of course it will never be more than 5 times the upper limit. So now since our patient had the 3 times upper limit, we are going to repeat it. So now, what do the guidelines say about repeating? There is this time interval to the second cardiac troponin assessment. We do this to reduce the delay in diagnosis. We like to do it to have shorter stays in the emergency department. And of course, low patient stays means lowers the cost. So our best option is to draw blood at 0 hours and 1 hour. So as the nurse draws the blood, you would mark that time, and exactly 1 hour after that, you would repeat it. Or otherwise, if that is not feasible in your setup, you could do it at the 0 hours as the patient, the time the nurse draws the first blood sample, and then you can go to the 2 hours. And you have to also remember that even in the best of centers, it takes almost 45 minutes for the report to come back to the clinician. So if you're talking about the 2 hours, it's at about 3 hours time that you will actually get your second troponin report. So this slide, I think I can give it a quick skip because it was handled by the earlier speaker. But just to say that when you're diagnosing an acute MI, everything comes into play. His clinical history, the ECG, and the troponin as well. So on this actually scale, we can rule out an MI and discharge those patients, or otherwise we can rule in a Stemi and send them for intervention. So now we do our patients repeat troponin, and that comes same, 3 times upper limit of normal. Now what do? Are you happy now to send him off and say this is not acute coronary syndrome? What is there any further assessment that we can offer him? So now, if you look at the guidelines, so we have this patient either who are very low risk, which we have ruled out, and high risk, those people are going to go for angiogram anyway. So our patients falling into this category. And then our new recommendations are that you should go for a 3-hour high sensitive troponin. If you feel the patient's risk is high and his symptoms are suggestive, and you can combine that with the echocardiography that in most centers can be done. So you would go for a 3-hour. And also then, depending on that, you would decide whether you're going to go for a angiogram or not. So patients who do not qualify for rule out or rule in are designed to observe. This usually requires a third measurement of a cardiac troponin at 3 hours. And we can combine it with the echo. And you also remember that for patients with low to intermediate likelihood, we can now offer coronary CT. And of course, but not in our setup, but even stress testing and even cardiac MRI are indicated. This, I think, algorithm was also handled by the earlier speaker. It's a busy slide. It just goes to show that how they do 1 hour, and after that you wait for your repeat in 2 hours. And depending on that, if you're still suspicious, you can do the 3-hour sample. And then if there are no changes, then you can observe the patient. So in the guidelines, we have a new place for CT angiography. It is now considered to be equal diagnostic to coronary angiography in patients low to moderate risk. So we have this huge group of patients whom we are going to send off from the ED, whom we think are okay. Now in those patients, if we think that they have a moderate risk, there is a place to do a CT. CT can exclude coronary artery disease. It can exclude other causes such as aortic dissection. And of course, it has reduced costs and stay in hospital. But of course, you have to bear in mind that patients have tachycardia and a lot of calcium in the arteries, such as patients with severe rheumatoid arthritis. Interpretation of the CT can be difficult. So on to our next case. We have a patient who's 50 years old. He comes with a classical ischemic chest pain. His ECG has ST depressions. So his troponin is this time 5 times upper limit of normal. His blood pressure is a little bit low. He has a tachycardia, and he's in a little bit of pulmonary edema. Also, his serum creatinine is 300. So now this patient, does he need a coronary angiography? And if so, what would be the timing? So now, invasive strategy routinely is not recommended for a non-STEMI because we found trial-based it does not reduce all-cause mortality. And in fact, it can increase the procedural complications such as MI and bleeding. So these, once again, a little bit of busy slides. Well, just in summary, if the patients you're going to go for immediate invasive, less than 2 hours, these are very high-risk patients. These patients are unstable patients and their blood pressures are low. They have arrhythmias. They can present with heart failure and cardiogenic shock. And they have extensive ST depressions. And they also may have ST elevations in AVR and V1. Any of these criteria fulfilled, they would then be classified immediate risk and go in for immediate intervention. Early invasive comes to less within 24 hours. So these people are with a GRACE risk score, which I will discuss, of more than 140, and they also have presumably new ECG changes. For everybody else, of course, we can have a selective approach. So these people with this GRACE score and established STEMI diagnosis, these will have angiograms in less than 24 hours. So our risk assessment of our patients consists of the troponin, which we have discussed, the serum creatinine, the age, the GRACE score, and of course it's recommended to do the BNP, which we cannot routinely do in our setup, and a GRACE and the bleeding risk assessment. So the GRACE score is actually available on the internet. You can just type in these variables such as age, heart rate, blood pressure, creatinine. With the patient is in pulmonary edema, it would give you automatically your score. So once we did it for our patient, our score came to 143. So a score above 140 is considered high risk. So he needs early coronary angiogram. This is a slide that would just show the patients who would have a high bleeding risk score. Just to keep in mind that you should look for end-stage renal failure, low hemoglobin, any spontaneous bleeds. So I'm not going to go through it in detail for lack of time. The next case. So we have a 55-year-old man who presented with a non-STEMI. Finances is not a problem. What would be your best dual antiplatelet regime? Would you give him aspirin and clopidogrel, aspirin and ticagrelor, or aspirin and prasugrel? So if we look at the recommendations, the new recommendations, aspirin is recommended for all patients. And a P2Y is recommended in addition to aspirin. And you can maintain it over 12 months. These are all class 1 recommendations. So that could be prasugrel, ticagrelor, or clopidogrel. But with the new trial data, we think prasugrel should be considered in preference to either ticagrelor for non-STEMI patients, especially if they're high risk and you're going to go for an intervention. These are the doses, which I will again not go through in detail. So with the new trial data, this patient would be put on aspirin and prasugrel, and the trial is the ISA-REAC 5, which showed a significant benefit with giving prasugrel. So next we have a patient who has peripheral vascular disease. He had a non-STEMI. He came to our center and got stents into all 3 of his vessels. Now, how long should you continue dual antiplatelets? Should it be 12 months? Should it be more than 12 months? So now we have extended dual antiplatelet for secondary prevention. It can be considered in moderate to high risk of ischemic events, and if, of course, there is no risk of any major bleeding. So this is I just want to tell you about the risk criteria for extended treatment. All you really need to know is this, that if you have used 3 stents and you have treated at least 3 lesions and your total stent length exceeds 60 millimeters, and of course, where most of our patients have the rest, they are diabetic, they have a history of recurrent MI, then of course they fall under high thrombotic risk. And certainly there is a place for you to continue dual antiplatelets beyond 12 months. So this is the extended dual treatment regimes. So this we all know. So clopidogrel at 75, prasugrel and ticagrelor at either 60 or 90. And of course we can use rivaroxaban at 2.5 BD, but you have to ensure that the patient is also on aspirin. So now if you consider anticoagulation for non-STEMI, what we are going to assess is the bleeding risk, which we discussed earlier. And so if your bleeding risk is low, we can give these patients aspirin and ticagrelor or prasugrel or clopidogrel, this combination, for 3 months. And thereafter, we can continue with ticagrelor for 12 months. If your bleeding risk is high, then you will be giving aspirin and clopidogrel for 3 months. And you will be continuing for the remaining 12 months with aspirin. If your bleeding risk is very high, then of course you'll be stopping aspirin and clopidogrel combination at 1 month, and you'll be continuing with clopidogrel. So you can see as your bleeding risk increases, you'll be using less potent antiplatelets, and we consider clopidogrel to be the least potent. And as your bleeding risk is low, and if the patient's ischemic risk is high, then you'll be going to more potent dual antiplatelets. So our patient has a high thrombotic risk because he's diabetic, he has peripheral vascular disease, he has had a MI, we have put in 3 stents. So we've decided to do dual antiplatelets for more than 12 months. So what about the patients who come with atrial fibrillation? How will you manage them? So in patients with atrial fibrillation without mechanical valve prosthesis, we prefer non-vitamin K oral anticoagulants over vitamin K anticoagulation in terms of safety because they have a lower bleeding risk. So dual antiplatelets with NOAC at the recommended dose for stroke prevention, and a single antiplatelet therapy. We prefer clopidogrel because it's chosen in more than 90% of cases in the trials, and it's recommended for up to 12 months. It all sounds a little bit confusing. I think this slide will kind of explain it. So if you look at atrial fibrillation patients, we have patients with high bleeding risk and high ischemic risk. So if you have a high bleeding risk, you give them the triple therapy. That's the NOAC plus dual antiplatelet for up to 1 week. And since the bleeding risk is high, then you go down to NOAC and a single antiplatelet agent, most often clopidogrel, which you can continue for 3 to 6 months. Thereafter, you'll be going with NOAC alone. And if you decide you want to more than 12 months, it'll be NOAC alone. Now, high ischemic risk, then of course we have to do with the triple therapy for 1 month, such as what we discussed, multiple stents, more than 60 millimeters of stent. And then after that, and with atrial fibrillation, then you go with NOAC and a single antiplatelet agent for 12 months. But of course, if none of these risks are present, then of course we can do the triple therapy for 1 week and simply continue, which majority of patients will fall into this group. You just give them NOAC, their dual antiplatelets for 1 week, then you just continue with NOAC and clopidogrel for 12 months. After 12 months, you decide whether you're going to do it more than 12 months or not, based on what we have discussed. And also, like the earlier speaker, just a few words about lifestyle management. Long-term management, it's all handled by Dr. Vajira, who spoke earlier about lipid-lowering drugs, the importance of ACE inhibitors. Just really a few words. I'm sorry that this slide is not very clear, but our LDL goal would be, we'd like to keep our LDL goal achieved at least 4 to 6 weeks. And if we cannot achieve that goal by that time, which is less than 55 milligrams per deciliter, we would add either ezetimibe or otherwise we could add a new agent. ACE inhibitors and beta blockers are both indicated for patients whose ejection fractions is low, and also MRAs are recommended if the patients have heart failure. And proton pump inhibitors also have now class 1 recommendation to combine them with aspirin monotherapy. So this is a busy slide. So in summary, I'd just like to say that non-STEMI is a frequent hospital diagnosis, and your important steps to follow will be risk stratification, deciding on your antithrombotic regime, your revascularizing decisions, which will be based on how you have categorized them, and also you cannot forget your secondary prevention. Thank you.
Thank you, Tanya, for that excellent presentation. And as we said earlier, we'll take the questions as last. Over to you, Marudha.
Thank you. Our next topic is treating dyslipidemia, bridging the gap, by Dr. M.R. Mubarak. He's a consultant cardiologist. Dr. Mubarak, over to you.
President-elect Dr. Daminda Munidasa, Ceylon College of Physicians, Dr. Mayuradhan, President, Sri Lanka College of Cardiology. I thank the colleges for inviting me to give this lecture on dyslipidemia. And I have to thank Dr. Disna for inviting me and telling me what should I talk. So I am talking according to her instructions, and this lecture is based on her guidance. So now, treating dyslipidemia, I have selected the topic, bridging the gap. Everybody treats dyslipidemia. Everyone knows what to treat and how to treat, and we give statins to everyone. So, but there is a gap between the evidence and the practice. So I like to highlight this by 2-3 cases of case presentations where we will discuss where we go wrong. So why do you treat dyslipidemia? That is the first question we have to ask. Hypertension, diabetes, smoking, dyslipidemia, obesity, unhealthy diet, lack of exercise are the modifiable risk factors, which we all of us know. But dyslipidemia is unique. It's a major factor necessary to drive the atherosclerotic process. If there is no dyslipidemia, there is no plaque. So that is, the plaque consists of lipids. So we have to specifically treat dyslipidemia in the management of risk factors. So whatever risk factor you have finally end up in the plaque formation. Plaque basically consists of cholesterol. So the primary objective of treating dyslipidemia is to prevent cardiovascular disease and death. And on the left side, what you see on the screen, you can see angiogram pictures of plaques, and you see the postmortem and the histological. So we have to avoid this coming, as Dr. Vajra Senaratne and Tanya talked, STEMI and non-STEMI cases, and we should prevent patients from going to this state. So that is the purpose of preventing dyslipidemia. It is not just to get a beautiful lab report when they come next time. So you have to make the patient do not get these complications. That is the basic you have to understand. Why we are treating? To prevent a heart attack and a death or a stroke. So we highlight a case, a 46-year-old diabetes for about 10 years, a long time diabetic, had a TIA 1 year ago, and she recovered. Atorvastatin 10 milligram daily she was taking, and presents to us with an infraposterior STEMI and ejection fraction 40%. So probably this patient will be having triple vessel disease from the ejection fraction 40%. We know that there is extensive muscle damage to this patient, and she was thrombolized, as you all know, as you instructed earlier, and she was started on atorvastatin 40 milligram in the ETU, as the guideline says, and the lipid profile was done. So now you analyze this lipid profile, where we get our confusion stage, where we see a total cholesterol of 137 and the LDL cholesterol of 68. And when you see this report, and you are a little confused, and the lab report down says rechecked and confirmed. Sometimes patient panic, the doctors panic, and the house officers panic. Now what to do? Are we going to continue this 40 milligram, or what are we going to do? What is the guideline says? So now we'll ask these questions. I want the audience to respond, if you can, please. So stop atorvastatin and recheck the lipid profile in 6 weeks. Will anyone do this? No, we will not do that. But we did this. When we were registrars, we do, at that time it was lovastatin, and we wait for 6 weeks for the lipid profile to come to start statins. That is how we learned. But the things have changed over the last 20 to 30 years. This is how it was treated at the beginning. We wait for 6 weeks for the lipid profile to come and to see the lipid profile, and then we start statins. That was the treatment. So now we don't do that. We should not do that. Reduce the dose of atorvastatin to 10 milligram daily on discharge. Can we do that? No, we don't do that, but people do that. But that is wrong. Continue atorvastatin 40 milligram daily? Yes, that we should do. We should continue the 40 milligram irrespective of our lipid profile report. But it's a difficult decision because the patients will question, the lab will ask, as they have said highlighted, and they have put it low, and the patient must ask you, when the lipid is low, when it is low, why should I take this 40 milligram? So you should be able to explain the situation. Can we go back to simvastatin 10 milligram daily? No, simvastatin 10 milligram is a low intensity statin. That is not recommended after Stemi, because you have to go for a high intensity statin. It has to be either rosuvastatin or atorvastatin. And stop atorvastatin and restart in 2 weeks? No. I have seen patients not given statin on discharge because the statin lipids had been low and they have withheld, and it had been patients come with these reports. Therefore, these are the gaps we have in our evidence-based practice, and we should avoid these things, and we should be able to explain this to the patients and the patient party, because they are now educative. They have their mobile phones, they have their WhatsApp, they have their Google, and they will check with these things. When the lipid is low, sometimes these lab reports give bad impressions to the patients. You give a dose of statin and they look at the report, and when it is say normal or low, they think that we are over-treating these patients. So we should be able to highlight these guidelines. So we all know major outcome trials have validated. Lower the LDL, the mortality is less. Here we see when the LDL goes down and down and down in the line, cardiovascular risk is going down and down. So that is, there is no risk in having a low LDL or very low LDL. So to understand this basic thing, we'll just go back to the intestinal cell biochemistry. Chylomicrons, the lipid absorbed in the form of chylomicrons, that is triglyceride-rich lipoproteins, entering the capillaries, lipoprotein lipase digests the triglycerides and form chylomicron remnants. These are taken up by the liver, and the liver produces the VLDL. VLDL is highly rich, triglyceride-rich lipoprotein, which has certain amount of cholesterol. And it is converted to LDL, that also has cholesterol but triglyceride-rich. And finally, you get the LDL, which is the cholesterol-rich lipoprotein, which is our target of therapy, and that is taken up by the liver. So when you take these three all together in one go, the chylomicron remnants is the one which is produced at the beginning, and then we'll come to VLDL, IDL, LDL, and LPA. What you see here is all contains the protein ApoB, and ApoB. All four contains the ApoB lipoproteins. Therefore, all these contains from the same apoprotein is there in this all four lipoproteins, out of which the LDL cholesterol is the cholesterol-rich lipoprotein, LDL and lipoprotein A. When you measure LDL in the laboratory, part of that is LPA, LP little a, is there included in this one. And some of them are genetically have high LPA. Those are high-risk individuals for atherothrombosis. And VLDL and IDL also contains cholesterol, and that cholesterol is called atherogenic triglyceride-rich lipoproteins. So this lipoprotein plus LDL part forms the non-HDL cholesterol, which is atherogenic lipoproteins. The whole of this spectrum is atherogenic. Even though we talk about the LDL as our target of therapy, we also should know that VLDL, IDL, and LP little a all are atherogenic, and we should target all these in our management. So when you take the basic, why all these are atherogenic? Because this is how it is taken up by the endothelium for a process of transcytosis. What you see in this picture, the chylomicrons will not enter into the transcytosis process, but VLDL remnant, IDL, LDL, and those all three can get into the endothelium, into the intima, and cause inflammation and plaque formation. How does this go? It all depends on the size of the particle. When you take the LDL particle, it is around 25 to 30 nanometers. Ideally, it's little bigger than that. And VLDL remnants are around 50, 60, 70 nanometers. Any particle less than 70 nanometers can cross this endothelial barrier by a process of transcytosis, can cause inflammation. So even now we know that not only the LDL, even IDL and VLDL remnants can cross the barrier. Once that cross the endothelial barrier, most of them come out into the circulation, but little bit of them remain in the endothelium, in the intima, and cause inflammation, oxidation, and start the atherosclerotic process. That basics we should understand in the atheroma formation. So in the current concept, lipid management, we have the LDL cholesterol is the major risk for atherogenesis. That we understand because it's a smaller particles, it can cross the endothelial barrier. So that is the primary target of therapy. Any lipid profile, you assess the LDL. Cholesterol is also carried by VLDL and IDL, that we know, and that is also atherogenic. That is called residual risk. Once the LDL cholesterol is reached the target, you look at the VLDL and IDL. How to look at the VLDL and IDL? All together come into a non-HDL cholesterol. So you take the total cholesterol and subtract the HDL. The whole part is the non-HDL cholesterol. It is, when you say non-HDL cholesterol, all cholesterol which carries the ApoB lipoprotein. So when you treat these patients, you don't treat the HDL cholesterol. We don't give drugs to increase the HDL cholesterol. It is just a risk marker, and we don't treat, and we don't depend on the total and the HDL cholesterol. So when you are treating, this is how we should analyze our lipid profile. So this is the latest recommendation by the ESC, the target of therapy. When the patients, all what you treat is according to the patient's risks. It is not by looking at the lipid profile. You have to look at the patient's risks. When the patient falls into very high risk or high risk, I will come to that later, what is very high risk, take care, intensely manage the lipids. These are the patients who will end up in Stemi and non-Stemi. So we have to prevent that. Their target of therapy is 55 milligrams, very high, and high risk is 70 milligrams. So these two patients, not only that, you take the baseline level of this patient and see that it is more than 50% reduction from the baseline. That is important. If the patient's LDL cholesterol is 100 at the baseline, and if they are falling to very high risk, you should have a 50% reduction. You have to bring it below 50 milligrams. That is the target of therapy, and see that it is below 55. That is how it should be interpreted. So this below more than 50% reduction, because whatever the LDL cholesterol patient is having is a high risk for him, for his background. Therefore, you have to have a 50% reduction of LDL cholesterol in this patients with very high risk and high risk. Moderate risk, you don't have 50% reduction, you have a target of 100. Low risk, 116. So most of our patients which we deal in the hospital setup fall into high risk and very high risk, and please prevent them from falling into a Stemi or non-Stemi. But there is another high risk individual, extreme risk. Extreme risk are patient who had two artery involvement, two territory involvement. A patient who had a stroke and patient had a myocardial infarction. Within 2 years, they fall into extreme risk. Here the target of therapy is less than 40 milligrams per deciliter. That is a less than 40 milligrams per deciliter. For example, in our patient, you can remember, last year he had a TIA and this year coming with a STEMI. So within 2 years, he has two territories are involved, the cerebral circulation and the coronary circulation. Therefore, she is extreme risk, and her target of therapy should be less than 40 milligrams. So that should be the treatment, and the 40 milligram atorvastatin may not be enough for her. You may have to add ezetimibe to this patient to make more aggressive during the initial stages of the myocardial infarction. The initial stages of myocardial infarction are the time where they are very highly inflammatory. They can get reinfarction, they can get rethrombosis, they can get stent thrombosis. So these are the time we should have aggressively treat these patients with high intensity statins and ezetimibe. So these are the two groups which you know, very high risk category. I have put a big numbers like the bus number, route numbers, 55. This is the 55. Very high risk group, target is 55. High risk group, target is 70. So documented ASVD, any patient with stroke, myocardial infarction, stenting, CABG fall into this category. Not only that, even the patients who have undergone CT coronary angiogram, and if they show more than 50% plaques in two territories, they fall into this category. So then next is the diabetics with a target organ damage. the diabetic with a microalbuminuria or retinopathy, falling into three major risk factors, very high risk. Long-term diabetic, type 1 diabetes, severe CKD, familial hypercholesterolemia with AVSD, and calculated risk score. So all these fall into high-risk category, and see that their target is 55 milligrams per deciliter to prevent them from getting myocardial infarction, stroke, and death. That is the target of treatment. So when it is high risk, when somebody is having a total cholesterol of 310, that is a high risk. You don't have to calculate anything. You start with high-intensity statins, and target is 70. Anybody having LDL cholesterol of 190, target is 70. Diabetes without target organ damage, diabetes duration more than 10 years, it's a high-risk category. So these are the categories you should remember to treat aggressively. Otherwise, you don't wait till patient get myocardial infarction or stroke, and then you start with a high-risk, high-intensity statins. So you have to prevent them from getting these complications. So why can the LDL cholesterol be too low? Yes, it can be too low. What is your LDL cholesterol when you are born? When you are born, our cholesterol is less than 30 milligrams per deciliter. And we see this graph is so. When you are born, we are born with less than 30 milligrams. And with our growing up time, we acquire our change in lifestyle, and we become higher. When the LDL rise with age, the higher risk of atherothrombosis is higher. The plaque formation, fatty streaks, plaque formations, all when the LDL goes up. And when you talk the ancestral history, and we see the mouse, rat, monster, and human is the ones which has the highest amount of LDL cholesterol. So it is historically, it depends on our lifestyle. So when you have shown that these PCSK9 inhibitors, these are anti-cholesterol agents, subcutaneous drugs, and these drugs have shown marked reduction in LDL. Here the mean LDL is 21 milligrams. Here mean LDL is less than 30 milligrams. Those trials, the patient have been observed for more than 6 years, and there were no adverse effects. Therefore, we know that low LDL doesn't cause any major adverse effect to these patients. What is the worry? The patient thinks so many things about this LDL cholesterol lowering. Even the physicians, consultants, even the doctors, the educated people, they think, even a professor, I had a difficult time in managing, a professor of biochemistry, giving him statins. So experimental, epidemiological, randomized clinical trials, genetic studies, there are genetic variants where the LDL is very low due to mutations, and these patients didn't have any of these risks: increased risk of cancer, increased risk of hemorrhagic stroke, no CV deaths, no neurocognitive dysfunction, no sexual dysfunction, no hormonal abnormalities, and this had been demonstrated. Therefore, low LDL is safe. So in the treating the LDL cholesterol goal, there are one thing which you have to remember. First thing is lifestyle modification. Then you go to statins, highest recommended dose or the highest tolerable dose to the patient. And if not so, you add ezetimibe and the PCSK inhibitors, which is available in the world, and we don't have those ones. And new drugs are in the pipeline, not in the pipeline, already FDA approved, pempidoic acid, reduce the LDL cholesterol. Inclisiran is also in the pipeline. FDA to be approved, and LDL apheresis. These are the targets to reach our armamentarium to reach the target. What managing dyslipidemia in the real world? Observational studies done in the UK, USA on patients on lipid therapy 1 year after myocardial infarction. This is not in Sri Lanka, this is in Europe. 35% on atorvastatin 40 to 80 milligram, rosuvastatin 20 to 40 milligram, 35%, one third are on target reaching doses, 45% on low or moderate doses of statins. Even we see here 10 milligram or 20 milligrams of atorvastatin. 5% on funny doses of statins. What is 2.5 milligram every day, weekly ezetimibe fish oils, and 15% not on statins. So this is the findings which they found in UK and USA from the insurance data and the drug charts. But the other studies which have done in Europe, Eurospire, DICES, Eureka, Da Vinci study, the latest study, all shows about 1/3 of the patients are on target reaching doses of statins. So what are the barriers? Barrier to the bridging the gap between evidence and practice. What is the barrier? There are 3 barriers. One is patient-related barriers. Patients should understand that it is the importance of taking statins and keeping to the lower doses. So we have to educate the patient, and we have to take time to tell them that these drugs are important drugs. Sometimes what I see, the atorvastatin available is only 10 milligram in the government sector. When you give 4 milligram, 10 milligram 4 tablets, patient may not be taking all 4 tablets. They usually take 1 tablet, and at the end of the month you check their leftover drugs. There will be enough and enough of statins available in the bag because they have taken only 1 tablet or 2 tablets. Very difficult for them to swallow 4 tablets at a time. So that is one particular reason I see. But in the private sector, of course, you have 40 milligram tablets available. That is easy for the patients to take. Healthcare system related factors, that is the availability of the drugs, the insurance, we have enough drug is available for the time being, and physician related factors. So even our physicians should know what should be the target of therapy and how should be treated. So that is, all 3 factors are important in bridging the gap between evidence and practice to cross the barrier. So one important thing what you have to talk is the statins, the side effects of statins. There are many side effects, and out of all side effects, what we talk about is the statin-associated muscle symptoms, that we should take it seriously. But every symptom what the patient comes and tells, the backache or shoulder pain, or you should not attribute to the statins, because statins can cause symptoms. Their CPK is normal, and this can be, you can reassure the patient. If the patient can tolerate, we have to tell them that these are life-saving drugs, prevent you from getting another stroke or another myocardial infarction. You should continue to take it. And sometimes they are worried about liver enzymes. So liver enzymes are not liver damages. Patient asks for the liver damage things. It is not liver damage. It is just transaminitis. We can use increase in mild elevations of SGPT. Hepatotoxicity is very rare. And sometimes, very rarely, patients can get rhabdomyolysis. You should take note of those symptoms and do a CPK and see whether, in that case, the CPK is elevated thousands of times than the normal. What is nocebo effect? Nocebo effect. Nocebo effect is an effect where you explain to the patient that when you take these drugs, you might get side effects like backache and back pain, and patient is waiting for that effect to come. Whenever the patient gets the next backache, she will come and tell that, rush to you and say that I am having a backache, and it is due to the statins. So nocebo effect. What common example what I see is this vaccine these days, the booster dose. Anything, everything what is happening the following day is due to vaccine. So that is like nocebo effect. The patient has a bad expectation, negative feeling about the drug or the vaccine, and they attribute that to what happened yesterday or recently. Now I am coming to a new thinking. What is clinical inertia? It's a failure to initiate therapy or to intensify or damage therapy to establish appropriate targets or treatment goals. That is in the physician's hand. You know that the target is there. You know that patient will benefit. You know that we have to increase the dose of statin, and you don't do that, and you wait for the next time. For example, this is done mostly in diabetes. When you want to start insulin, you wait for the next visit, or wait for some time for the insulin and give more time without immediately taking the decision. It is common in all chronic diseases including diabetes, hypertension, dyslipidemia. The causes of clinical inertia is multifactorial. It may be due to the patient factors, it can be due to the physician factors, it can be due to the system. The finding, for example, to get the things organized, it might take time. For example, in other countries, what they have said is start a PCSK inhibitor. They have to wait for months to get the approval from the insurance company to get the system work. So those are the factors which cause inertia. Studies have shown that clinical inertia has significant impact on healthcare outcomes. So that is one reason for bridging the gap between evidence. So I'll quickly go through a few cases, and the case history is a 55-year-old. I hope you all to answer these questions. 55-year-old hotelier, consumes alcohol, smokes, no regular physical activity, no family history, BMI is high, blood pressure is elevated, HbA1c 6.1, and his lipid profile is 189, 280, HDL 30, and LDL not looking very great, not very high, 99. How will you treat this patient? Anybody? I will give you the answers. Now look at the lipid profile. You know the history. Obvious thing is triglyceride, which is high. Recommend fenofibrate 200 milligram daily. Anybody going to do that? That is what we normally do it, because when you look at it, you look at the triglyceride, it is the biggest number, you treat the biggest number. It is not that, right? Why we are treating? We are treating to reduce cardiovascular mortality and death and mortality and cardiovascular events. So in that, we know that the LDL is our target of therapy. So you have to treat the LDL. Then you go to the non-HDL. So atorvastatin 10 milligram, rosuvastatin, maybe. He does not need any lipid-lowering drugs therapy. We have to wait and see. Advise high in strength omega-3 fish oils, that also you might do, right? Whether it is going to help him to reduce cardiovascular death and mortality, that is what we have to worry. So estimate the global cardiovascular risk. So this is a patient who doesn't have cardiovascular disease. And this patient has a primary prevention we are going to treat. So whether we are going to give statins or fenofibrate or fish oil, or we just educate him. So look at this cardiovascular risk. Whole global cardiovascular risk should be estimated. So to that, this is the recommendation. If somebody is having in the age range 40 to 65, if you have a cardiovascular disease, diabetes, CKD, familial hypercholesterolemia, or the total cholesterol is more than 310 or LDL 190, you don't estimate the risk. They automatically fall into high risk or very high risk. You don't estimate. But if they don't have any of those things, you have to estimate the risk. That is what we are going to do for these patients. So this patient doesn't have any of those. Therefore, we will be estimating the risks chart. We have to use the risk chart. So there are many charts. WHO chart is available for Sri Lanka, Indonesia, these countries a chart, and you can go for European chart, here the ESC chart, and your gender, age, smoking, and you calculate the chart according to these 5 criteria, and his 10-year risk is 5 to 10%. His 10-year risk is he's falling into high risk category. So we know what is a high risk category. 10-year risk is 5 to 10%. Therefore, he is falling into a high risk category. So when somebody is a high risk category, we know that, I told you the number, it is the 70 milligram is the target. His LDL was 99. So he is high. So you have to bring down to 70 milligram. That is the first thing we have to do. So first thing what you have to do is treat any secondary causes of elevated triglycerides by hypothyroidism, alcohol, and all those things, and aggressive lifestyle changes on diet, regular exercise, stop smoking, alcohol, optimal blood pressure and sugar control, and prescribe statin to achieve a LDL target of less than 70 milligram. So here to keep him in, because he is a high risk individual. So if the LDL remains high, more than 70 milligram remains target, and if the remains elevated despite statin treatment, then you give the fish oil. High strength omega-3 fish oil should be given. At the beginning, if you give the omega-3 fish oil, what omega-3 fish oil will cause is, it will convert the VLDL into LDL and reduce it, and your LDL will go up. The next time when he comes, you might see that LDL is 135 or 140, and you are wondering what has happened, right? So first, treat the target of LDL, bring down the LDL, and when the next time he comes after 6 weeks or 3 months, and then you see what it is, and then you give the fish oil. And then next time he comes, that fish oil we have given, fish oil is not given to reduce the triglyceride. It changes the inflammatory markers and other things in the plaque. Once the LDL is reached less than 70, and if you have given enough fish oil, and if the triglyceride remains 200, you give fenofibrate. Fenofibrate is given not to reduce mortality or anything, to reduce the numbers, especially to prevent pancreatitis in very high triglycerides. So what happened to this patient? This patient was on fenofibrate. 5 months later, he is coming to the ETU with a burning chest pain, inferior STEMI, primary PCI to mid RCA, cardiac rehabilitation done, and on atorvastatin, and he is doing well now 5 years. So this is what happened to this patient. So this patient was given fenofibrate. So we didn't treat his lipids to reduce cardiovascular mortality or death. We treated just to pick a number, to reduce that number of triglycerides. So that is how we should treat patients. That is the evidence and the practice, the gap. So is dyslipidemia different in South Asians? Yes, South Asians have a different dyslipidemia. What is the dyslipidemia in this patient? Low HDL, high triglyceride, moderately increased LDL cholesterol. LDL didn't look high when you look at the reports. It looked about 90, 100 and that. And they have non-HDL cholesterol is high. High levels of small dense LDL particles, elevated ApoB particles, and high LPA. That is why South Asians are high-risk individuals. So in South Asia, in India, Bangladesh, Sri Lanka, these countries fall into South Asian atherogenic phenotype because they, unlike in the West, in the Western numbers, the triglycerides are not very high like that. Their cholesterols are high. So they treat cholesterol. Here we have to consider the non-HDL cholesterol. So this diagram shows how the particles are higher. Here you see the LDL cholesterol in both patients, 99 milligram. So when you take this LDL cholesterol is here, number of particles are 4. Therefore, number of FOB particles are 4 and the LDL is 99. But in South Asians, the particles are smaller. The LDL particles are smaller and high dense. Therefore, you have so many 14, 15 particles causing 99. Therefore, this is more atherogenic than this, even though the numbers are same. So both having 99 milligram, but this in South Asian phenotype, it is more atherogenic because the particles which enter into the endothelial barrier is high. Number of particles are high. It carry more cholesterol into that and cause inflammation. So that is why in the Indian guidelines, which I have been also part of this guideline, Lipid Association of India Expert Consensus, and in 2016, I have been involved in since 2016, and the target for LDL cholesterol for very high was less than 50, they decided at 2016. And 2019 European guideline recommended 55. Therefore, that's why South Asian phenotype is very aggressively you have to treat. So what is LDL target in diabetics? So when you know diabetics, I will not much time here. 2/3 of the diabetic patients end up in cardiovascular death or disease, strokes and myocardial infarction. So when you have diabetic, they either fall into very high risk or moderate risk. So whatever it is, the target should be 55, 70 and 100 milligrams. What is this 100 milligram? Just a new onset diabetes, young diabetic, less than 50 years, diabetes during 10 years, their target should be less than 100. You see that when you treat diabetics, they keep it below 100 milligram, younger diabetic. When they get complications, it becomes 70. When they become more and more risk factors added, it becomes 55. So all diabetics come onto a high risk, moderate risk or very high risk category. So just come to another last case. A 47-year-old school teacher, diabetic for 6 years, on insulin, glycoside 80, metformin 500, sitagliptin 50, and rosuvastatin 5 milligrams. So what is this patient? This patient is diabetic for 6 years, premix insulin 5 milligram. What is her cholesterol? 139. 139 looks normal for this reference range. This is a school teacher. She will teach others and she also learns from the reference range and she thinks that cholesterol is normal. So LDL cholesterol normal. This is the misguidance by these reference laboratories, and patient had been taking 5 milligram rosuvastatin. This is very inadequate dose. So patient's target should be at least 100 depending on the risk chart. So he presents with an acute chest pain, anterior Stemi. After 3 years, 100% occlusion of mid-lead AD, primary PCI done, uneventful recovery, and she was discharged on atorvastatin 40 milligram and ezetimibe 10 milligram. She became a very high risk individual. We have converted the moderate risk into a very high risk, and now we are giving very high dose of statins and ezetimibe. So what is the gap between evidence and practice in this case? LDL was 139. Was it normal? The lab report says normal range. That is the misguiding. It's the reference range. We should not go by that. Mislead the reference ranges? Yes. Patient educated people, always when they take the report, they say it is normal, and whether it is within the range, they think that they are normal. So that is not the way. And first thing what you have to say is not to look at those reference ranges. This individually, case by case, we have to treat the patients. Rosuvastatin 5 milligram is inadequate. She should have been a higher dose of statin to keep the target 139 to below 100. Was there any side effects? Why didn't they take it? There should have been side effects. So look for any side effects. Why she didn't take that one? Patient prefers lower dose. Some of them try to take lower doses. They are very fond of taking 5 milligram doses. But this is mostly inadequate and it is not in the any target ranges. It may not produce any lowering of the statins. Knew the current guideline recommended doses. We have to, before treating, we should know the guidelines and what is the updates. And is there an element of clinical inertia? Possible. Is it a failure of primary prevention? Yes, we have not done the prevention part of it. So therefore, in treating dyslipidemia, First, you have to take the cardiovascular risk category. That is the first thing you have to take, cardiovascular risk category. It is not treating the lipid profile report. You take the risk category, whether a patient belongs to high risk, very high risk, moderate risk, or mild risk, or mild individual, or it can be extreme risk. So first know the risk. Then you should know the baseline LDL cholesterol level, where the patient stands. Where is the LDL cholesterol? Is in one patient it was 99, other one 139. We know that both are high for these individuals. It's not the number according to the reference ranges. Guideline recommended goals we should know. So when the patient belongs to what category, what is the guideline? What is the guideline? If it is a very mild individual, 116, moderate risk 100, high risk 70, and very high risk 55. So that we should know. And the duration. Once the patient you are treated, patient goes home, take the medicine and come back next time, and the LDL is below 55. And now what you do, you reduce the dose to half. That should not happen. We have to keep on the duration. That is important. The patient is happy. Dr. Beheta Dunna, now we have got this. Now it is 55, it is low. Now they are happy and they are waiting till you tell that you are going to reduce the medicine. It should not be done. It should continue, persistently treat this, because this is the duration of treatment is important to prevent the next cardiovascular death. If you reduce the dose into half or make it 10 milligram atorvastatin, and if they end up in another myocardial infarction or stroke in 2 months' time, then you will regret what I did was wrong. So the patient will not realize that, right? They are waiting to reduce the doses because they don't have the knowledge of this cardiovascular risk. So magnitude, duration, reduce the cardiovascular risk. That is my take-home message, and I hope, thank you for your participation in bridging the gap between the evidence and practice in dyslipidemia management. Thank you.
Thank you, Dr. Mubarak, and we'll move on with the last presentation for the day before starting the Q&A session.
Yeah. Thank you. The last presentation of the day will be done by Dr. Disna Amaratunga, Consultant Cardiologist, District General Hospital, Negombo. She'll talk on management of heart failure across the ejection fraction spectrum and new updates. Over to you, Disna.
Thank you very much, Dr. Mayuradhan, for your kind words of introduction. Good afternoon to all of you, ladies and gentlemen. Today I'm going to discuss about the management of heart across the ejection fraction spectrum and new updates. So, what is heart failure? Actually, the general population would recognize it as the failing or dysfunction in heart. But when it comes to the medical terms, understanding is usually the failure of or the dysfunction of the ventricle. So over last decades, several classifications, definitions, as well as the categorizations came out. However, finally, the latest definition of classification classifies different phenotypes according to the left ventricular ejection fraction. So today my aim is to take you across this new classification. And now, according to the new universal definition, we have 3 main categories. So that is depending on the left ventricular ejection fraction. The main 3 categories are heart failure with reduced ejection fraction, and that is the ejection fraction less than 40%, and the heart failure with mildly reduced ejection fraction, that is the EF in between 41 to 49%, and the third one is the heart failure with preserved ejection fraction. That is when the ejection fraction is more than 50%. So now, in addition to that, the NYHA functional class assessment, which has been there from good olden days, are still existing, and that is based on the severity of symptoms and the physical activity. As you all know, the class 1 is no limitation of physical activity, and class 2 is light limitation of physical activity, and class 3 is marked limitation of physical activity, and class 4 is unable to carry out on physical activity without discomfort. Now, again, the ACC-HA staging system is also existing still, and according to that, this classification mainly stages the heart depending on the, to evaluate the development and progression of the disease. And the NYHA classes focus on exercise capacity and the symptomatic status of the disease, but this one, the ACC-HA staging, will mainly focus on the, focus to evaluate the development and progression of the disease. Now, this is just to highlight you, and this is just to show you that there are, millions of people are living with heart failure across the globe, and annually billions of money spent on them directly as well as indirectly. Now, we are directly moving into the heart failure with reduced ejection fraction management. Now, we all know the classification is that ejection fraction is less than 40%. Now, the diagnosis will basically depend on having the target ejection fraction of less than 40%, together with symptoms plus or minus signs of heart failure. Now, when it comes to the management of heart failure with reduced ejection fraction, we have 4 basic weapons. So, they are the mineralocorticoid antagonist, beta blockers, SGL2 inhibitors, as well as the ARNI, that is the angiotensin receptor neprilysin inhibitors. And when this ARNI is, when the settings are not favorable to start ARNI, we would go for the ACE inhibitors. So we'll move into this drug management. Now, when it comes to these 4 foundation drugs, all these drugs, the mechanism of action are independent and additive. We do have several other drugs. We will be dealing with them in later. Now, when it comes to this, to the ESC 2021 guideline recommendation, all our 4 drugs are there in which carries the class 1 recommendation. And you all know that an ACE inhibitor is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. And we all know that the consensus and the SOLVIT trials that we had in initial phase, they have which was done with enalapril, has proven the mortality as well as morbidity benefits. And in addition to that, the number 2, this beta blocker is recommended for the patient with stable heart failure to reduce the risk of heart failure, hospitalization, and death. Once again, it is also class 1A indication. And once again, we have these our all trials and the studies. Those are the Copernicus, CBIS-2 trial, as well as MERIT trial. And it stands for class 1A indication. And the mineralocorticoid receptor antagonist is recommended for the patients with heart failure. Once again, that is always. Now, this is also to reduce the risk of heart failure, hospitalization, and death. That is also goes as class 1 indication. And this dapagliflozin or the empagliflozin, that is the SGLT2 inhibitors, also now we recommended them for to use as class 1A indication to reduce the risk of hospitalization and cardiovascular death. So I will be dealing with these drugs later. And now when it comes to sacubitril valsartan, it is recommended as a replacement for ACE inhibitors in patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death. Once again, it is class 1A indication, but level of evidence B. Now, when it comes, now we all know that the ACE inhibitors, when it comes to this sacubitril valsartan, this ARNI, that is the angiotensin receptor neprilysin inhibitor, the major trial which was carried out to compare the ACE inhibitors and this ARNI, that was the Paradigm Heart Failure trial. In the Paradigm Heart Failure trial, it was proven that sacubitril valsartan is superior to enalapril in reducing the all-cause mortality, hospitalization from heart failure, as well as the CV, cardiovascular mortality. So because of that, it was recommended that ACE inhibitors or the ARBs is replaced by this drug in ambulatory patients with heart failure with reduced ejection fraction. Who is having symptoms despite the maximum optimal medical management. But anyway, the washout period of 36 hours is needed in order to avoid the bad angioedema. However, the Paradise trial, the results of the Paradise trial was released in last year. Actually, it was mainly done to compare the sacubitril valsartan with the ramipil, that is mainly to determine the superiority in reducing the heart failure events following MI. Even though the favorable observations are there for ramipril, at the moment, still more supportive informations are there to continue already existing guidelines to replace it. And then we are moving into the other drugs. We have several other drugs like ivabradine, digoxin, hydrolyzine nitrate combination, loop diuretics, and the Vascular, that is the soluble guanylate cyclase receptor stimulator, as well as the omecamtiv. These are the newer generation drugs, as well as ferric carboxylates. So now, if you go back to the previous slides, you will realize that our all major drugs, they are to reduce the risk of heart failure, hospitalization, and death. And when it comes to the other drugs, now this is the loop diuretics. These diuretics are recommended in patients with heart failure with reduced ejection fraction with signs and symptoms of congestion. This is to alleviate the heart failure symptoms and as well as to improve the exercise capacity and to reduce the heart failure hospitalizations. And there's no mortality benefit from this loop diuretics. And when we go to this ivabradine should be considered in patients only with who are in sinus rhythm. And when this in sinus rhythm and the resting heart rate is more than 70 beats per minute, despite treatment with an evidence-based dose of beta blocker or maximum tolerated dose below that, to reduce the risk of heart failure, hospitalization, and cardiovascular death. And anyway, the ivabradine should be considered in symptomatic patients with left ventricular ejection fraction less than 35 in sinus rhythm and a resting heart rate more than 70 who are unable to tolerate or have contraindications for beta blockers, that is to reduce the risk of heart failure, hospitalization, and cardiovascular death. Now, this soluble guanylate cyclase receptor stimulator that may be considered in patients with NYHA class 2 to 4 who have had worsening heart failure despite treatment with ACE inhibitor or a beta blocker and mineralocorticoid receptor. That is our optimal medications therapy. So this one, now the recent studies, that is the Victoria study, so it has revealed that it will reduce the incidence of primary endpoints of death from the cardiovascular risk as well as the hospitalization from heart failure. But anyway, it has not shown to reduce the all-cause mortality of all-cause mortality. So because of that, at the moment, this is it stands as 2B indication. And this hydrolyzine and isosorbide nitrate combination, actually small study was done on black patients. So once again, it stands as 2A indication for the patients with heart failure with reduced ejection fraction. And when it comes to the digoxin, now digoxin, we have been using this drug over many years, but anyway, the DIG trial has neutral effects on overall mortality. So the digoxin may be considered in patients with symptomatic heart failure with reduced ejection fraction in sinus rhythm despite treatment with ACE inhibitors, a beta blocker, and mRNA to reduce the risk of hospitalization. But anyway, the use in symptomatic heart failure with AF and rapid ventricular rate when the other options are limited. So that is the main indication that we are using the digoxin. Now, when it comes to this all drugs, now in the initial phase of this 4-drug concept, they have introduced this sequential introduction of drugs. So according to the initial phase, now the step 1, they say that to go for the beta blockers plus SGLT2 inhibitors. Now, the reason behind that is the beta blocker generally, it most effective for risk of sudden cardiac death, so it goes as the step 1. And then at the same time, SGLT2 have striking early benefits for hospitalization for heart failure, and it will also reduce the short-term risk of worsening heart failure with beta blockers. And then when it comes to step 2, addition of ARNI within 1 to 2 weeks of step 1. So that is or either angiotensin receptor blocker, or if the systolic blood pressure is less than 100 mercury millimeter, we have to evaluate the tolerance before adding these drugs. And but anyway, the risk resolves with repeated dosing or adjusting the diuretic dose. Now, step 3 is addition of mineralocorticoid receptor antagonist. That is within 1 to 2 weeks of step 2 if the serum potassium is normal, as well as if the renal function not severely impaired. So now the favorable effects of SGLT2 and ARNI to improve renal function and potassium homeostasis may increase the tolerability of this mineralocorticoid receptor antagonist. And most important thing is that all 3 steps achieved within 4 weeks and the uptitration to target doses thereafter. And even though we have this rapid sequencing, is it really necessary? Now, the efficacy of each foundation drug class is independent of treatment with the other drug class. So, the historical sequencing is not mandatory. And the background therapy can influence the tolerability of the other foundation agent. So, the proper sequencing should account for better combination therapy. Low starting dose of foundation drugs have meaningful therapeutic benefits, and broad-based coverage should be prioritized before uptitration. Mortality and morbidity benefits evident within 4 weeks of initiation of therapy. Now, because of that, now from this ACC 2020 guidelines, they have asked us to go for, tailor-made approach rather than going by the sequential approach. Now, in addition to that, now we have given this drug management. We have to understand that another pathway for the management is also existing. Now, if the patient is having left ventricular ejection fraction less than 30%, 35%, there are indications for ICD implantation and the non-ischemic as well as the ischemic. I will be discussing this at the end of my presentation. And also there is a place for CRT therapy, especially if the patient is in sinus rhythm with the left ventricular ejection fraction less than 35% and the QRS duration is more than 130 milliseconds. Now we'll move into the heart failure with mildly reduced ejection fraction. That is the ejection fraction in between 41 to 49% category. Now this ESC guideline recommendations to diagnose, actually, we have to have the presence of symptoms and signs of heart failure and mildly reduced ejection fraction and the presence of elevated BNPs. So those are the, the supportory the criteria. And also there should be other evidences of structural heart disease, that is like increased left atrial size, LVHO echocardiographic measurement of left atrial filling. So the presence of these evidences make the diagnosis more likely. So, and what is the most important part of recognizing this as a major category? That is because the heart failure with mild reduced ejection fraction may benefit from similar therapies to those with left ventricular ejection low left ventricular ejection fraction. This support the renaming of heart failure with mid-range ejection fraction to heart failure with mildly reduced ejection fraction. Now, when we go to the recommendations, the ESC 2020 guideline recommendation, that we have the patients with, all the class 1 recommendations that we use for the patients with heart failure with reduced ejection fraction is there, but when here it is most of them are in class 2B. So the class 1 indications are the diuretics. They are recommended in patients with congestion and in order to alleviate the symptoms and signs. All the ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, as well as sacubitril valsartan, they all come under class 2B indications. Now we'll move into the heart failure with preserved ejection fraction. That is when the ejection patient is having the symptoms and signs of heart failure and the left ventricular ejection fraction is more than 50. Once again, we should have the it's easy for us if we are having the objective evidence of cardiac structural or functional abnormalities consistent with the presence of left ventricular diastolic dysfunction as well as raised left ventricular filling pressure and also the raised BNPs. Now, the patients with the history of overtly reduced left ventricular ejection fraction that was less than 40%, who later present with left ventricular ejection fraction more than 50%, should be considered to have recovered from heart failure with reduced ejection fraction. Right? So, heart failure with improved left ventricular ejection fraction rather than heart failure with preserved ejection fraction. So in these patients, continuation of the treatment for heart failure with reduced ejection fraction is recommended. Now, when we come to the management of heart failure with preserved ejection fraction, if we go through all these trials, now the various agents over the year have failed to demonstrate benefit on hard outcomes in the management of heart failure with preserved ejection fraction. Anyway, now the recent trials that empagliflozin, the Emperor Preserve trial, has anyway shown that is the first as well as the only agent to demonstrate benefit in patients with heart failure with preserved ejection fraction with or without diabetes with consistent benefits in patients with or without diabetes. So because of this reason, I just thought of discussing these SGLT2 inhibitors in heart failure, in the management of heart failure. Now the sodium glucose co-transporter inhibitors, the rationale for exploiting this molecule is that diabetes and heart failure have the similar pathophysiological features. So they have the endothelial dysfunction as well as they have insulin resistance. In addition to that, the mechanistic effects of SGLT2 inhibitors are seen in patients with and without diabetics. So they have better diuretic effects as well as better metabolic effects. And the cardiovascular benefits of SGLT2 inhibitors are largely independent of glucose levels. Now, the indirect actions of SGLT2 inhibitors in cardiac function. Now, you all know these SGLT2 inhibitors acts through the kidney and it will have favorable effects on glycosuria and it will have favorable effects of natriuresis as well as diuresis, and because of that the heart will have favorable hemodynamic effects by reducing the systolic blood pressure, reducing arterial stiffness as well as by reducing plasma volume, and also the favorable metabolic effects will cause to heart to have the protective action against the heart failure, that is by reducing the body weight and reducing the hyperglycemic state as well as by reducing the glucose toxicity. And in addition to that, these SGLT2 inhibitors will have the effect on afferent arterioles, so it will increase the release of erythropoietin, which in turn regulate the circulating progenitor cells as well as inflammatory cells, and which in turn will have favorable effects on heart, and it will increase the oxygen delivery as well as to reduce the left ventricular mass. Now, we have direct as well as indirect actions of SGLT2 inhibitors into the heart. We have discussed the indirect actions more now, and we'll now move into the direct actions. Now, heart, because of this molecule, it will cause the, improve the endothelial function of the heart, because, and it was also improve the myocardial autophagy, and as well as it will inhibit the cardiac fibrosis. Now, because of all these effects, finally, due to the indirect effects on indirect effects as well as the direct effects on heart, finally the SGLT2 inhibitors decrease the severity of heart failure. Now, when it comes to the heart failure therapies having the diuretic effects. Now, when we go through this, the adverse effects, if we compare mineralocorticoid receptor antagonist, loop diuretics, SGLT2 inhibitors, thiazides, and acetaminophen, you will realize that with the SGLT2 inhibitors, the incidence of hyperkalemia, hypokalemia, and all these electrolyte disturbances will be minimal. And in addition to that, SGLT2 inhibitor, it's once daily dosing, and it's a single dose one, and titration of dose is also not needed. So do we have trial evidence to prove these actions? Now, when it comes to the Emperor-reduced trial, that is mainly done to assess the efficacy of this molecule in heart failure with reduced ejection fraction. So they have done it with the empagliflozin 10 milligrams. So they have the confirmatory endpoints, and as well as this, the confirmatory endpoints were the composite primary endpoints as well as the secondary endpoints. Now, when we got to the primary endpoints, now this with the empagliflozin, it reduces the cardiovascular death or hospitalization for heart failure, and you will realize it has a significant p-value. And then when it comes to the total hospitalization for heart failure, once again the empagliflozin arm is favorable. So once again it has the significant p-value. And the key secondary endpoints, so the empagliflozin protected the kidney by slowing the progression of kidney disease. And once again, this p-value is significant. So now, this, from this Emperor-reduced trial, we have the confirmatory evidence of efficacy of this molecule in heart failure with reduced ejection fraction. So when we take all the primary endpoints, key secondary endpoints, and the eGFR slope, all confirmatory evidences are there. And in addition to that, the empagliflozin also reduced the composite renal endpoint, that is the end-stage kidney disease, so sustained profound decrease in eGFR. And also, the clinical benefits of all-cause mortality or worsening heart failure was evident from day 12 onwards. If you just compare these charts, you will realize this arm, it has the evidence from day 12 onwards. So, these SGLT2 inhibitors in heart failure with reduced ejection fraction. Now, even though the SGLT2 inhibitors used to be a type 2 diabetic management drug, now guidelines recommend it in the management of heart failure with reduced ejection fraction. It requires single dose once a day without titration. So, in patients with heart failure with reduced ejection fraction, empagliflozin significantly reduced the risk of cardiovascular death or hospitalization by 25% versus placebo in patients with or without diabetes. Now, and it also reduces the total hospitalization for heart failure, and also it reduces the composite renal outcome by 50%. And when it comes to the heart failure with preserved ejection fraction, we do have our trial evidence to show that it is beneficial. Now, the Emperor preserved trial, that is once again done with the empagliflozin. So, 2/3 of these patients in Emperor preserved trial has the left ventricular ejection fraction more than 50%, because you know that to begin with they had the LV ejection fraction more than 40%. Anyway, later after the analysis, they have found out that the 2/3 of the patients were having the LVEF more than 50%. So the data are validated for this entity, and the both components of the primary endpoints, cardiovascular deaths and heart failure hospitalization, contributed to the beneficial effects. Now, if we take this graph, you will realize that it has the 21% relative reduction in the composite primary endpoints of cardiovascular death or the heart failure, so with the significant p-value. And then it also has the confirmatory secondary endpoint, reduce the first-time recurrence of hospitalization by 20%, once again with significant p-values. So, and it also protects the kidney by significantly slowing the decline in kidney function. So when it comes to the Emperor Preserved trial, once again, the specific endpoints that we have the confirmatory evidences to say that it is effective, and all the primary endpoints, key secondary endpoints were met. And now, even though we have the evidence, still it is not there in the guidelines, but if approved for the treatment of heart failure with preserved ejection fraction, empagliflozin would change the clinical practice in the management of heart failure with preserved ejection fraction. Now, in addition to that, I would like to touch on this device management a little bit, because we know now when we, in the management of heart failure with reduced ejection fraction, there is a place for ICD implantation as well as the place for CRT devices. Now, according to the latest ESC recommendation, the ICD, this is the implantable cardiovalvular defibrillator, that is the ICD, we use it as a secondary prevention, and this ICD is recommended to reduce the risk of sudden death and all-cause mortality in patients who have recovered from ventricular arrhythmia causing hemodynamic instability. So this goes as class 1A indication. And when it comes to the primary prevention, that is that ICDs recommend to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure of an ischemic etiology, unless they have had MI in the prior 40 days and left ventricular ejection fraction less than 35%, despite more than 3 months of maximum therapy, provided they are expected to survive substantially longer than 1 year. So this is once again 1A indication. So when it comes to the primary prevention, this 2A indication is newly introduced into the guideline. So an ICD should be considered to reduce the risk of sudden death. That is for the non-ischemic etiology as well, because in the previous slide, if we go back, you will realize that this is for the ischemic etiology. So now for the ischemic etiology, ICD has got class 1A indication, and with the introduction of new guidelines for the non-ischemic etiology also, it has a place with 2A indications. And anyway, the ICD implantation is not recommended within 40 days of MI, as implantation at this time does not improve the prognosis. And now we'll move into the, this cardiac resynchronization therapy. So the cardiac resynchronization is recommended for symptomatic patients with heart failure in sinus rhythm. When the QRS duration is more than 150 milliseconds and the LBBB QRS morphology, and with the LVEF less than 35% despite maximum medications, in order to improve the symptoms and reduce the morbidity and mortality. So it goes as class 1A indication. And anyway, now once again, this was introduced into guideline, latest guideline. So patients with the CRT should be considered for symptomatic patients with heart failure in sinus rhythm with a QRS duration of 130 to 149 milliseconds with LBB morphology and with LVEF less than 35%. And this goes as class 2A indication. And now this anyway, the CRT rather than RV pacing is recommended for the patients with heart failure with reduced ejection fraction, regardless of NYHA class. So this goes as class 1A indication. And anyway, CRT is not recommended in patients with QRS duration less than 130 milliseconds who do not have an indication for pacing due to high degree AV block. So then we'll move into the, the key changes to the heart failure in reduced ejection fraction treatment in 2021. And the new class 1 recommended therapy for heart failure with reduced ejection fraction is the SGLT2 inhibitors, dapagliflozin and empagliflozin. The 4 drug therapies should be initiated as quickly and safely as possible. And the importance of tailor-made management rather than, the sequencing management was highlighted. And the primary prevention ICD in non-ischemic cardiomyopathy is now comes into class 2A indication, and the emphasis on broad LBBP in selecting patients for CRT we have just discussed. Thank you.
Thank you, Dishna, for that excellent presentation. We'll start the Q&A session. Can we have the mics to the all speakers to share? And first, I would like to ask anybody from the audience, live audience, to ask if there are any questions. Please put your hand up, so we'll send you the mic. Anybody? Okay, sure. There are a few questions from the virtual audience. Can I ask Dr. Mayuran to read out them and ask? You can direct to one of them.
Yes, this is. Yeah, the first question is directed to Dr. Vajira Senaratna, I think. Still, do we practice liquid diet in the first few days, and when could the patients with STEMI following PCI or thrombolysis could start walking physical exercise? Mainly they're asking about the liquid diet and the walking and the exercise.
I don't think there's any guideline with regard to that. And most of our patients, I said, when you get MI, you assess the LV function and the arrhythmia. If those two, the LV function is good, then no arrhythmia, the patient should be able to mobilize within the next day itself. And the fluid diet, I don't think we practice anyway. No, I don't think. We have to give the calorie about 1,200 from day one, because otherwise they get wasted. So you give about 200 calorie diet with, but you can't give heavy diet, you can light diets. But you can mobilize day 2, provided that his LV function is not affected and there is no arrhythmia. It all depends on there's a now current days, they recommend to discharge the patient even the day 2, provided that there is no LV damage.
Thank you, sir. This is related to both Dr. Vajira Senaratna and Dr. Tanya. So, madam, which antiplatelet is preferred for long-term continuation after dual therapy in STEMI and non-STEMI management? They are asking what antiplatelet you will select from this aspirin, prasugrel, antigrel for both in non-STEMI and STEMI.
Tanya, okay.
Generally, actually, the current guideline, they recommend actually both drugs for 1 year, and ideally ticagrelor is the most potent drug. You can give 60 milligram BD long term, because most of the bleeding complications are due to aspirin. Early then, even most of the patients after stenting, we can recommend stop aspirin after 3 months and continue with ticagrelor after 3 months. That is in, of course, stable patients. In my patients, all the patients should be on 1 year unless there's high bleeding risk. But even long-term, ticagrelor is the best drug, but of course, I don't know if you can afford it to give ticagrelor. But aspirin itself has a lot of problems. All the bleeding problems are related to aspirin. So I think most of the people recommend, the guideline recommend to stop aspirin early.
Tanya.
And also, I'd like to add that you should assess the bleeding risk, and if the bleeding risk in the patient is high, we set the bleeding risk scores, then of course we prefer to continue with clopidogrel versus prasugrel and ticagrelor.
Thank you. Again to Dr. Vajira Senaratna. So regarding STEMI management, if patient on warfarin with INR more than 2.5, do we have to still give unfractionated heparin?
The patient's elevation MI, of course, the recommendation is even though the patient is anticoagulation, we should give routine, the heparin, heparin during the procedure, during the elevation MI. You should not stop unless there's high bleeding risk. I clearly told that it has to continue while giving the heparin.
Then what are the cutoff for troponins for rule in or rule out values? High sensitive troponin, they are asking. High sensitive troponin, rule in or rule out.
So I think I gave it in my first slide. There's a sex difference, and for males it's 0.032 and for females it's 0.016. But also you should take into consideration the serum creatinine also if the patient is in heart failure, serum creatinine, but those are the two reference ranges actually given on all our high sensitive troponin reports. It differs from lab to lab. The ranges that I gave are what are the ETU currently at NHS.
And you said that when there's a doubt, when there's a equivocal value, you go for the 3-hour troponin.
Yes, because
what is the rise you are looking at 3-hour value?
So now what we say is the first one should be at least more than 5 times upper limit of normal. If you don't get that it's something between 3 and 5, then you go for the 2 or the 1. But if it is more than 50% elevation from your first level, then you would consider it this significant.
Okay, thank you.
Comes early, then of course you have to do 3. If the patient comes several hours later, I don't think there's much point doing 3 hours. But the patient comes very early after chest pain, then you have to do 3-hour test before excluding non-STEMI. The question, the previous question, of course, each patient has to be, you have to evaluate each patient separately. You can't go, guideline is a general guideline, but you should be able to, you should assess the renal failure patient, elderly patients, like high bleeding patients. You can't continue both together.
Again, for the acute coronary syndrome, what is the place for ACE inhibitors, beta blocker, if there is no heart failure in patient with acute coronary syndrome on discharge, and when to start? They are asking the role of ACE inhibitors and beta blocker if there is no heart failure in acute coronary syndrome.
Actually, the class 1 recommendations now, actually, if this, the ejection fraction is lowered. So if the patient has a normal ejection fraction, actually, we don't have a class 1 recommendations to start these drugs. I can ask that from Dr. Vajrasenathan, sir. Do you have any different opinion?
Of course, beta blockers, there's indication, but those are not class 1 indications. After all, they might, but there's risk of arrhythmias. So prevent arrhythmias, I think there's place for beta blocker, but it doesn't come under class 1 indications.
Mayurudhan, can I ask a question from Dr. Mubarak? I just want to know whether there's any way that we can actually routinely measure these very high density small LDL in Sri Lanka.
Yeah, in measuring the LDL, the particle size, the small dense LDL can be measured. Our labs can entertain those tests and they send it to overseas, I think to India, and get the reports. And they don't do it here. Can be done.
Right, the next question also to Dr. Mubarak. So if a patient less than 40 years comes with high LDL, more than 190 million deciliter, without any other risk factors, what should be his LDL target?
If you get a patient, a young patient coming with LDL of 190, above 190, we should strongly think whether it is familial hypercholesterolemia. Heterozygous familial hypercholesterolemia should be excluded. So you have to get a good family history and see whether any family history of hypercholesterolemia and completely examine the patient for other features of hypercholesterolemia. So xanthelasma, tendon xanthomas, and arcus, and look for these things. If these features are there, it's highly suggestive of familial hypercholesterolemia. And if it is 190, we should aggressively treat these patients, because even if it is so, they are high levels, and even though the guideline says it is 40 to 65, but if it is less than 40, but nowadays they have say that all individuals should have their lipid profile checked during the college entry, the university entry, that is the 20-21 year age group. So because the atherosclerosis process starts not after 40 years, it starts at a young age. So if you have all the individuals, according to the Western guidelines recommendations, should start by the college entry. Around 20-21 years, they should have a lipid profile checked. And if the lipid profiles are extremely high like this, we should start on statins and reduce the levels. And lifestyle modification is anyway recommended. But if there's a strong family history of hypercholesterolemia, familial hypercholesterolemia, even in the year 2, year 3 years, young age, pediatric age, they should check their lipid profiles.
I have another question also to Dr. Barak with the same thing, that if you mentioned that you're going to do the younger age group routine, and if there are females and if you found they have high lipids, LDL, are you going to treat?
Being female, we should not avoid treating those people.
No, that's because of childbearing.
Childbearing age is a different issue. Yes. Just because they are females, we should not divide of the management of lipid, because they are also human beings and they have the same risk as males. So if in the childbearing age, when you start treating, you have to ask whether they are going to get married recently, whether they are going to have a family. Look at these things and then start treating these patients. And giving statins during pregnancy and contraindications is defined as contraindication. The statins are contraindicated during pregnancy and lactation. So you have to ask these questions, whether they are going to get married or whether they are going to married and they are going to have children. And once that is excluded, definitely you should give the statins. And always you should remember these things. Some of these patients coming with in 30-35s may be lactating. So we have to see that whether they have a lactating baby and ask those things. And sometimes we may have to stop or advise other forms of treatment, dietary and exercise for those management. And recent studies they have done on these patients very recently, last year, they have analyzed those patients really who were taking statins during their lactation by knowing or unknowingly, and they have found that there were no major adverse events seen in these babies as predicted earlier. So it's within inverted commas, it's safe. But in the future, in a case which are familial hypercholesterolemia, where we have stented and there are patients who are coming with myocardial infarctions, we may have to give statins during the pregnancy and lactation period even. That will come in the future. Soon it will be, I think, documented and it will come.
Is there a category of isolated triglyceridemia with normal lipid, and how to manage? Normal LDL, normal LDL.
Yeah, there is nothing called normal LDL, as I said. The LDL we have to see. The patient's risk category should be assessed. If the triglycerides are extremely high, it can be a congenital form of hypertriglyceridemia. So whatever we know, the risk is the risk factor is the LDL, and we have to bring down the LDL. So if these patients assess the risk factor for that patient's age, other risk factors, diabetes, hypertension, and the background history, and assess the risk chart. And if they fall into a high risk or very high risk category, you start treating that. In that case, again you start and see that if the patient fall into very high risk, the target is 55, high risk it is 70, if it is a moderate risk, 100. And see that you bring down the LDL to that target first, and start with a statin and bring it down to that target. And once you bring that to the target, then you consider repeat after 6 weeks or after 3 months, you do it again and see whether it has come down. And we had to strongly advise most of these hypertriglycerides are due to dietary factors and their lifestyle changes. So stop alcohol, take high carbohydrate diet, reduce the high carbohydrate diet and regular exercise and change the lifestyle, and it will come down. If it has come down, you are happy. If it has not come down, you have to start omega-3 fish oil. So when it comes to omega fish oil, we should remember whatever fish oil in the market is not the one it is recommended in the guidelines. It is the icosapentaethyl. Icosapentaethyl, you have to give 4 grams, a very high dose of icosapentaethyl. Icosapentaethyl is a purified form of EPA. whatever we have in this market is EPA DHA. So DHA is not recommended. The DHA is not good. So what it increases the plaques. It is harmful. So what you have to do is a high strength icosapent ethyl, 4 grams should be recommended for these patients in addition after the statin is given. And once that is given for 3 months or period, and even then still the triglycerides are high, then you can go for a phenofibrate.
Next question to Disna. What is the current heart failure management mainly concerns about this empagliflozin? Is there any age or renal targets for this?
Yes, actually in the trial what they have, the patients who has been allocated to the trial, they had the EGFR more than 30 because this molecule acts through the afferent arteriole, so and also it has good the effects on diuresis, natriuresis. So because of that, the function in kidney and the arteriole should be there. Nephron should be there to get the efficacy. So because of that, it is needed the EGFR more than 30.
So my question is, if it will be harmful if we give, if it is maybe the functioning tubules should be there, but can we try?
No, it's not harmful. You can try, but the efficacy will go because it was shown that it has. It has good effects on the renals as well, so it's not harmful, but the effects will not be that overt.
Elderly, the age group?
That of course I don't have very good idea, but I don't think that there is a significant limitation was not there.
Okay, we have run over the time. I would like to thank all 4 eminent speakers for participating in this session and time they have taken to prepare for this and for presentation. So on behalf of Ceylon College of Physicians, I would like to present a token of appreciation as form of certificates. So can I have all 4 speakers, Dr. Ajira Senaratne, Dr. Tanya, Dr. Mubarak, and Dr. Disna back on stage to accept these certificates. Thank you. And I can ask my co-chair to join me. So on behalf of the college, thank you for the live audience and the virtual audience for being with us, and also the college, the Sri Lanka the College of Cardiology Sri Lanka for being with us, and for not only for this session, I think this whole month was cardiology for specialty updates. And I think we have a cardiology quiz at the end of the month. So please participate in that. You can find the details in the CCP website. Thank you very much.
Thank you. I also take this opportunity to thank the Ceylon College of Physicians, and mainly to select the first month as a cardiology month, giving more importance to cardiology. Thank you on behalf of Sri Lanka College of Cardiology.
Thank you.